Today's discussion is on paracetamol poisoning, also known as acetoaminophen poisoning. This is one of the common and potentially life-threatening condition which usually occurs due to accidental ingestion of paracetamol or incorrect dosing of paracetamol in case of children. So today we shall see the toxic dose, the clinical features, pathophysiology, investigations, treatment and outcome of this poisoning in children. Coming to the toxic dose, in children less than 12 years old, more than 150 mg per kg single ingestion is toxic, whereas in adolescents and adults, more than 7.5 to 10 gram total dose in 24 hours is toxic. It is seen in children less than 10 years, they are remarkably resistant to hepatotoxic effect of paracetamol. Now let's see the normal dose metabolism of paracetamol. There are two reactions which occurs in normal condition. Phase 2 reaction is occurring in 90% cases, and this is a non-toxic pathway. So this pathway is followed in case of children, so they are more resistant to paracetamol poisoning. Here the paracetamol conjugation occurs by sulfation in 20 to 40% cases and glucuronidation in 40 to 65% cases. So the conjugates are water soluble and easily excreted in the urine, and this is non-toxic to the body. Whereas 5 to 10% cases, they have phase 1 reaction. This is toxic pathway and toxic to the body. So here the paracetamol is oxidized by cytochrome 4p P450 enzyme system, mainly by CYP2E1 to N-acetyl P-benzoquinone imine, shortly known as NAPQI, and this is highly reactive toxic intermediate metabolite which cause damage to the organs, especially the liver. So NAPQI is rapidly detoxified by conjugation with the glutathione and excreted in the urine in the normal condition. Now let's see what happens if there is a overdosing of paracetamol. So here glucuronidation and sulfation pathway gets saturated. So when it gets saturated, which is a non-toxic pathway, so when they get saturated, more of cetamol is diverted to CYP2E1 enzyme system, where there is increasing production of NAPQI, which is a toxic metabolite, and glutathione stores are depleted in paracetamol overdose. So NAPQI cannot be detoxified, so it accumulates as toxic metabolites and primarily cause damage to the liver. There is a hepatic necrosis, and then leading to acute liver failure and even death if it is not treated in time, and also progresses to multi-organ failure if untreated. So timely intervention is very essential. Now let's see the clinical journey or the different phases of paracetamol poisoning. 0 to 24 hours there are mild symptoms with nausea and vomiting. After that 24 to 72 hours the liver enzymes is raised, and then after that 72 hours to 96 hours there is hepatic failure, and this is the most critical phase of this paracetamol poisoning. At this phase there might be acute liver failure and the child may even require liver transplantation. If the intervention is not taken in time, there is death. So after this, after 96 hours there is recovery phase. So this time child recovers slowly, everything resolves. Now come to the clinical features based on the phase with the hours. So phase 1, half an hour to 24 hours time, the child may remain asymptomatic, or there will be anorexia, nausea, vomiting, pallor, malaise, and then diaphoresis. They sweat a lot. Phase 2, 24 to 48 hours time, There is resolution of the first stage, but liver, kidney and CNS is affected. So there is hepatic damage presented by abdominal pain at right upper quadrant, jaundice, deranged liver enzymes, especially AST and ALT, and there is prolonged prothrombin time. And there is damage to the kidney, tubular damage, tubular necrosis occurs, which is presented as oliguria and derangement of the liver renal functions. And then in CNS, there is cerebral edema, which may present as a convulsions or even coma. And phase 3, that is 72 hours to 96 hours, is the most critical phase of the paracetamol poisoning. Here again, the first phase, that was nausea, vomiting, reappears. Then there is hypoglycemia and the hepatotoxicity, it peaks. There is jaundice, and then child presents with a hepatic encephalopathy that is ultimately going into coma. There is acute liver failure and even death if the intervention is not taken. There is coagulation defects, and then there is myocardial injury, which is presented or seen in ECG as ST depression or elevation, and T wave inversion or flattening of the T wave is seen. CPK-MB is also elevated, and renal damage is presented as anuria, flank pain, hematuria, proteinuria. Then phase 4, that is after 96 hours, there is a slowly recovery. So it takes 4 days to 2 weeks for the complete recovery to occur. And resolution of hepatic dysfunction occurs, recovery in the survivors occur, and there is complete hepatic regeneration without any cirrhosis. So if you overcome the third phase, the outcome of paracetamol poisoning is good. Now come to investigations. Serum paracetamol level at 4 hours post ingestion, or at least 4 to 10 hours interval you should be doing the paracetamol level. Then you plot these levels on Rumack-Matthew normogram to determine whether this child is requiring antidote or not. So for the treatment part, this graph is, this normogram is very, very important. This normogram is only used for acute poisoning and not for the chronic. So now come to the Rumack-Matthew normogram. It looks like this, where serum paracetamol concentration is plotted in this vertical axis, and then in relation to time after ingestion is seen. So hours of ingestion is plotted in this horizontal axis. This is to assess the potential hepatotoxicity after single dose or acute ingestion of paracetamol. So it should not be used to evaluate the long term or repeated ingestions. It is used only for the acute or single ingestion. So here in the normogram, if the level is falling in the low risk, there is no need for the antidote treatment, whereas if it is falling across this over this, then you know there is a possibility of hepatotoxicity, so you have to use the antidote. So here the normogram, serum level 4 hours or more after ingestion is predicting the hepatotoxicity. So if you see here, this is 4 hours. In 4 hours, if the level, paracetamol level is 10, then this is falling in the non-toxic level. So you don't need to treat with the antidote. Suppose at 4 hours the level is 200 like this, then there is a possibility of hepatotoxicity. So you have to immediately use the antidote in this scenario. So investigations you will do is liver function test, the liver enzymes, bilirubin, prothrombin time, INR. This should be done daily, and then renal function test and glucose level should be also assessed. Now come to the management. Gastric decontamination is done if the child comes to you in the ER department within 1 to 2 hours after ingestion of paracetamol. You do this with the activated charcoal. Then after that you have to decide whether to use antidote or not using the chart and the normogram. So early treatment with N-acetylcysteine is very, very effective, shortly also known as NAC. N-acetylcysteine it replenishes the glutathione stores, which means glutathione is going to enhance the detoxification of the NAPQI, so reducing the liver damage. And it is most effective when you use this antidote at 8 to 10 hours after ingestion. And N-acetylcysteine, it can be given intravenous route or by oral route, and continue to use this even if symptoms resolve until the lab report normalizes, that liver function normalizes. You have to use this antidote. Now come to the protocol, how you're supposed to use. If you use oral N-acetylcysteine, then total dose is 1330 milligram per kg. That should be usually given over 72 hours. So within over 72 hours they improve. So dose schedule will be: loading dose you give 140 milligram per kg orally, then maintenance dose 70 milligram per kg orally, 4 hourly you continue for 17 doses, total duration 72 hours. And there is another antidote known as methionine, which is also given orally. Of this, only oral preparation is available, so you give this 4 hourly for 4 doses. But in practice, N-acetylcysteine is more frequently used than methionine. This is not available many places. Now if you give N-acetylcysteine by intravenous route, then the total dose will be 300 milligram per kg. You'll give over 21 hours. So the dose schedule will be: loading dose 150 milligram per kg in 200 ml 5% dextrose over 1 hour. After this, second dose you give 50 milligram per kg in 500 ml 5% dextrose over 4 hours. Then third dose you'll give 100 milligram per kg in 1000 ml 5% dextrose over 16 hours. Total 21 hours you'll take. Then you need to give supportive care to these children. Monitor liver function test, coagulation profile, renal function regularly. Every day you need to do this. Then treat the hepatorenal failure. You can use 10% dextrose, IV mannitol, correct the acidosis, correct the electrolyte disbalance, and if required you may go for dialysis, either peritoneal dialysis or hemodialysis. And ICU care for fulminant hepatic failure. And liver transplantation is done if the criteria for acute liver failure is meeting the King's College criteria. So you use King's College criteria to decide for the liver transplantation. So according to King's College criteria for paracetamol poisoning, when you are going to do the liver transplantation, so transplant is indicated if arterial pH is less than 7.3 regardless of encephalopathy, or all of the followings. Among these, if all these 3 followings are present, then also you have to go for liver transplantation. A, if the prothrombin time is more than 100 seconds or INR is more than 6.5. B, serum creatinine is more than 3.4 milligram per deciliter or more than 300 micromole per liter. Or C, grade 3 or 4 encephalopathy. If it is there, then you have to decide for liver transplantation. Now come to prognosis. With a timely and good management, prognosis is good. Mortality is just less than 0.5%. Patients who survive have no sequelae. This is one of the very good condition. Even though if there is acute liver failure, if they survive, they have no long-term sequelae. And severely affected patients require liver transplantation. So in brief, you should understand, especially while giving paracetamol to children, because paracetamol is a drug which is easily available and then everyone can use it. So in dosing you have to be very careful, because if the child gets a paracetamol poisoning, they can, in third phase, it is very severe and critical. They may require urgent liver transplantation. So if the facility is not available, there might be mortality of this child. So for the general population, it is very important to understand that you have to keep paracetamol in a safe place, that is accidentally children might ingest. And on a second point is, while giving the dose, you should be very careful, always follow the doctor's instruction. So this is the message for this class. Thank you. So in my next class I'll be talking on another poisoning. So if you find my class helpful, please don't forget to like, share and subscribe. Thank you.